So this session is very much about what we would call the multidisciplinary team, and about some of the treatment options that face our patients, and to kind of do a bit of myth busting as well, and really get across the fact of shared decision making is very real. And you've got some of the best speakers here to tell us all about that. As the presenters, we're taking questions through the chat, but we'll feed those in towards the end with Simon and myself. We've got hundreds of people watching on our Facebook Live channel, which is great. We've had real good engagement. We've got people here in the room, and we're seeing lots of followers through Twitter. So Simon, can we just upload the MDT presentation, and Simon can start us off? Here we go. Just close the last one down. So if you just want to ask for the new slide forward, Simon, we can.
Yep, we'll do.
Thank you.
So thanks very much, Will. So what I'm going to do is to talk a little bit about what is an MDT, and there are some headings up there on the screen already, which will cover the main areas that we're going to look at. Can we move on to the next slide? Thanks. Oh, sorry, go back one. My mistake. Yeah. Okay, we'll stay on this one for the minute. So I'm going to start off really with a generic statement that about an MDT is a multidisciplinary team, and that, for the purposes of bowel disease, includes a mixture of specialists, healthcare professionals with different areas of expertise within the broad theme of bowel disease. And the precise mix of those healthcare professionals will depend to some extent on the nature of the valve disease being discussed at the meeting. And there is often confusion between the terms MDT, which is the multidisciplinary team, and the term MDM, which is multidisciplinary meeting, and they're often really used interchangeably. And I think the second point I'd like to make is that we are in a process of very rapid change in the way that MDTs and MDMs work. And part of that relates to the changes that have been forced on us by the circumstances of the pandemic. And that traditionally, these were face-to-face meetings where a group of professionals sat down and looked at the results of the investigations of a particular patient. And that was done face-to-face in a room. Now, clearly that's been impossible over the last 6 months, and we've moved very rapidly to a situation where nearly all MDTs, MDMs now are run virtually. And we'll talk over the next few minutes about some of the pros and cons that are associated with that. So the next thing is who's involved. Well, as I've already mentioned, it depends a bit on the precise nature of the valve disease being discussed. So what I want to focus on, just by way of an example, is we'll take aortic valve disease. And when we're looking to make recommendations for a patient with aortic valve disease, there are a number of considerations that need to be taken into account, and these are reflected in the individual healthcare practitioners who are present in that meeting. So you need a cardiac surgeon, or at least one cardiac surgeon, somebody who's experienced in surgical techniques of aortic valve replacement. There will be usually 2 or 3 cardiologists present, one of whom will be an expert in valve disease or in the imaging of valve disease, so particularly echocardiography. One of whom will be a cardiologist, an interventional cardiologist, who is experienced in techniques of TAVI and other valve interventions. And there will often be other cardiologists present who may not have a specific interest in valve disease, but in other areas of cardiology which may be relevant to that patient. And I'll come on to mention a couple of these in just a moment. In addition to the cardiac surgeons and cardiologists. There will be specialist nurses with expertise in valve disease. There may also be cardiac physiologists with particular expertise in echocardiography. And not infrequently, there will also be other healthcare professionals involved, including, in some instances, care of the elderly consultants, because a number of the patients coming through for discussion will have, or most of them, in fact, will have other conditions, some of which are associated with issues like frailty, sometimes early stages of dementia. And these can be particularly problematic in selecting the right treatment for an individual patient. And we need these areas of specific advice to help that decision-making process. For the same reason, we will often have input into the MDT, if not actually an actual presence in the virtual room, from other healthcare professionals with expertise, say in kidney disease or lung disease, or sometimes in neurology as well. And all of these contribute to the discussion and advice decision-making process. And I think it's important to emphasize that probably the two most important people in the room are the healthcare professional who's chairing the meeting, who is responsible for summarizing the recommendations for each patient and ensuring that actions are taken, and the MDT or MDM coordinator, who is responsible for making sure that all the relevant documentation, all the relevant opinions, all the relevant information is present so that the correct decision-making process can be followed. How often do they meet? Well, that's variable. It depends from institution to institution, but it's important that they meet on a regular basis. And by that, I mean at a sufficient interval to make sure there is no unnecessary delay in decision-making. And generally, that will be at least weekly for most MDTs, sometimes more frequently. The role of the MDT has changed over the years. And the main driver for that evolution, the change in the function of the MDT, is that we now have a lot more potential treatments to offer potential patients with valve disease than we did a few years ago. At one point, it was just surgery. We now have a lot of other options. And so the range of MDT discussion is broadened out to look at all the potential options that we have for treating valve disease. And the principal role of the MDT is to weigh those potential options, the benefits and risks of each one, the evidence for and against the use of each one, in the particular circumstances of each individual patient, such that the decision-making process is thoroughly centered around the needs of the particular patient. And that has become increasingly important, as I mentioned, with the range of interventions that we have, but also with the fact that we are now offering treatments to both surgery and TAVI and other interventional treatments to patients who a number of years ago would have been considered unfit for those procedures, because our experience and the techniques that we have available have expanded considerably over the last few years. And to answer the last point that Will has raised, why is this important? And I think fundamentally it's important because this process provides the best means of reaching the right decision, to be able to provide the right advice to individual patients about what is best for them in the balance of the different options we have available, which may be surgery, it may be some form of intervention, TAVI or other catheter-based intervention on the valve, it may be medical treatment, or it may actually be nothing. All of these are potentially suitable options, and in order to be able to provide that advice, you need to have a rounded discussion with a range of expertise available. So next slide, please. Okay, so what I want to do at this stage, having provided a bit of an introduction, is to just ask my colleagues on the panel here to give some more detailed overview of specific aspects of the decision making. So first of all, if I can turn to you, Narain, and just some of the discussions that take place if it looks as though a surgical procedure is going to be most appropriate for an individual patient.
You're on mute, Narain.
Thank you, Simon, for that. And I think whatever treatment is chosen, I think it's important for the patients to understand that that discussion that has happened beforehand with the different specialists that will be involved in the patient's care, and to decide what is the best treatment. So when they come and see a surgeon in clinic, the first thing I would talk them through is the diagnosis. So what is their underlying condition, and what is the natural history of that? So what would happen to them if we were not to treat them with anything, so that they have an understanding of why we are considering treatment. To repeat the importance of what the process that has gone on before they meet us in clinic, the MDT process, that their treatment decision has been based on what is deemed to be important for them as an individual. So taking into account their age, their other comorbidities, their frailty, and what is important in their life. So to stress that the decision and the conversation with the surgeon has been generated by considered thought. To stress to them that my job as a clinician, as a surgeon, is to convey to them the important information regarding their disease and their treatment options. That importantly, it is the patient that will be making the decision. So my job is to inform them of how to make that decision and support them in that decision-making process. And then coming specifically to talk about surgery, the first thing I would talk to them is actually what the surgical technique would involve. So the process of general anesthesia, the different incisions. Joe will go on to talk about some of the minimally invasive options that we have for surgery, but the standard treatment for a lot of surgical procedures is to do a median stenotomy, which is an incision down the midline of the breastbone. So then for a majority of patients, again, for cardiac surgery, they're put on cardiopulmonary bypass, where the heart and lungs are stopped, so that they can understand the concept of that. And then when talking about different valves, for whether it's the aortic or the mitral valve, there are different options in terms of repairing the valve, preserving the patient's own valve, or replacing the valve. And then if a replacement is going to take place, there are choices between a tissue valve and mechanical valve. And that again is important to take into consideration the patient's own perspective on things and what's important to them. So whether longevity of the valve is important, ever having another operation again, or whether not taking warfarin, which is what would be required for a mechanical metal valve, where that has implications in terms of interactions with alcohol, other medications or antibiotics. So the trying to get out of them what's important to them, the different choices that exist, because there is no one valve or there is no one repair procedure that fits all, similar to different treatments, whether percutaneous or surgical based. I then go on to talk to them what the expectations are, what to expect beforehand, how long they would be on the waiting list for, what to expect after the operation. So their stay in the intensive care unit, all the tubes and lines that they would have in them, and at what stage those different things would come out, how they will feel after the operation in terms of pain, what things they'll be expected to do with the physiotherapist, and then how they will feel when they go home, how long they will take before their recovery period occurs, what they can and can't do in terms of flying and driving, and considerations like that are important to them to understand how they will progress after the operation. And then probably the most important part of the discussion for them is to understand how they've made that decision about surgery or other options, is the risks and benefits of surgery. What we expect surgery to deliver to them, so what it means to them, so what outcome are they looking for surgery before they put themselves forward for a procedure like that. So in terms of improvements in symptoms, reducing their risk in terms of valve disease, of developing heart failure, and also in terms of increasing their long-term survival. So what are the benefits to the patients in terms of both quality and quantity of life? And then on the other side of that, what are the risks that they are about to embark on? So risks to their life, and then important risks such as stroke and infection and bleeding. And also some patients encounter sustaining a heart attack after the operation, or may need intervention on the valve again. So trying to get an understanding of what is important to them, because ultimately going through a proper consent process is important to understand what is materially important to an individual patient. So those are the sort of factors that we would discuss. There's obviously a lot more that goes on in the consultation, but those are the sort of important things that we would go through in the surgical discussion.
Thanks, Narain. And I think it's a very clear explanation. I think the one thing that brings home to me is that there is a lot of information to impart to patients and their relatives in the course of that discussion. Actually, that could be quite daunting information. So we can perhaps come back onto that later in the last discussions point. So Joe, minimally invasive surgery.
Thanks, Simon. Thanks, Will, for putting this really good panel together. I'm flattered to be part of it. Simon, I think the problem with minimally invasive surgery is it is different things to different people. So I think it's a whole spectrum. Some surgeons just make a smaller skin incision and call it minimally invasive surgery. Others, split the sternum by half, and that's also minimally invasive surgery. But the real push that BISMIX as a group, and I'm really pleased Narain's on because he's an integral part of that group, is to try and kind of get some idea and standardization. And what we try and do predominantly is to sell an idea of a non-stenotomy approach. So where we're basically trying to do heart surgery, but not spreading the breastbone.
So that's a pretty good summary of the general approach.
The heart is really the good bit of the patient straight after, but everything else takes, sorry, can you hear me still?
Yes, yeah, go ahead.
So everything else takes another 6 months to recover. So the way in and the way out is the real problem. So we've found that it's the collateral damage of getting in and getting out that seems to affect patient recovery, patient experience. And we know time and again that if you look at 5 years, 8 years, 10 years, the results of cardiac surgery are excellent, but the first 6 months are probably the worst. And this is probably why minimally invasive surgery has taken a bit of an interest both among cardiac surgeons and the community at large, because we feel that if we could reduce this collateral damage in some way, then the big advantage of cardiac surgery, which are predominantly long-term, we could transfer some of that into short-term benefits as well, where people, get out quickly. So one of the first things we did as BISMIX was to look at the mitral valve, because there's been a minimally invasive mitral valve procedure for about 20 years. And one of our frustrations about 5 years ago when we formed BISMIX was that only 5% of patients in the UK were being offered that. And one of the good things is over the last sort of 5 years, certainly there's been increasingly more and more centers coming on board and more surgeons coming on board. And right now we are doing a randomized trial looking at minimally invasive surgery versus stenotomy. And Simon, you are very instrumental in helping us start that. So appreciate the effort, the sort of effort that you put in there. Now, what is minimally invasive surgery? It basically is doing the same operation. So we still go on bypass, we still stop the heart, and we still do hopefully just as good a procedure, but without going through the stenotomy. So we go through the side, we go through the ribs. Initially, when we start, we do spread the ribs just so that, we've got a better view. But over time, people start by putting a camera in. And a bit like the general surgeons have found, you can make much smaller incisions once your camera is in. And the good thing about having a camera is that everybody else can see what's going on. And we're very fortunate now with technology where we have 3D cameras with, 5 times magnification and excellent detail. So the first thing that BISMIX did really was pick 3 centers that had done minimally invasive surgery on the mitral valve for some time, and we reviewed our results. And we basically showed that if we matched these minimally invasive patients to patients with stenotomy, patients seemed to bleed less and go home faster, and certainly had less wound infections. So we published that in Heart, and that was a good start to look backwards. We then have set up this minimally invasive trial, which we would have finished by sort of October this year, but unfortunately, because of COVID, things have been delayed by 6 months. And we're hoping the 10 centers that are recruiting, we're recruiting 330 odd patients, half go into minimal access and half go into sternotomy. And we hope in 2022, we will have the results. And the 3 things that we're looking at is, 1, do we do a safe procedure, minimally invasive? Number 2, do we do a good enough procedure? So are the repairs done minimal access just as good as through a sternotomy? And 3rd, which is most important, and we think that's probably what the patients will be interested in, is how quickly do patients get back to what they consider as normal life? Because we all know sternotomy is a great approach, great procedure, but there is an element of recovery time. The final thing about what is a good patient, to be fair, patients are getting older, patients are getting sicker, patients are getting more obese, and all of them do better with a minimal access approach. But as BISMIX, what we're trying to do is sort of set this up in a more, I would say, responsible fashion, because we're aware of what happened with general surgery in the late 90s when everybody wanted to do, sorry, I'm getting called from theater, but I'll delay that for a little bit. One second. Hello?
Hello, sorry, Joe.
Yeah.
I called you before also that you were talking to someone else.
No worries.
Just let you know we are going to cancel the second case.
Thank you so much. Thank you.
There is, yeah, thanks. Bye.
Sorry, patient getting
Proof that you're actually working.
Apologies. So yeah, I think the last thing I want to mention is, as patients get older and sicker and frailer, a minimal access approach is the way forward to get them back home faster with less social care. But as BISMIX, we are aware that this needs to be done responsibly. We don't want to make the mistakes of general surgery where laparoscopy came on, everybody was not yet fully trained, started doing stuff, and there were all sorts of issues that unfortunately ended up in places that we would not like to see surgeons or patients. And so we're hoping a gradual but stepwise fashion will help. So I didn't want to go into too many details of minimal access, but I just want to make the point that it is a spectrum. And the most important thing is to speak to your surgeon. BISMIX has a plan for next year to have a registry, so we actually know how many surgeons are doing how many patients, because as you probably are aware from both interventional cardiologists and surgeons, is that we presume to do more than we actually do. So when you ask somebody how many cases you do, they all say we do 100. But when you actually start counting, the numbers are not always the same. So we're hoping the registry will help to put data and to put sort of denominators into people's experience. So that'll be the next step. But definitely I would recommend patients to speak to their surgeons about it and, you know, take it from there.
Thanks very much indeed, Joe. And it sounds like you better be heading off to theatre, but I think it's a great illustration of the fact that, you know, all the developments in valve disease are not just cardiology, that surgery is evolving rapidly as well. So that's a good point to bring in Phil to talk about TAVI and what makes a good TAVI case. Phil, over to you.
Thanks, Simon, and thank you for involving me in this discussion. So I'm a cardiologist, so I'm different from Joe. I'll apologise because the internet is slightly patchy here, so it may be that it's I'm coming and going a bit. Can you hear me at the moment, Simon?
Yes, loud and clear.
Yep,
Okay,
I can hear you as
perfect.
well.
It's like Britain's Got Talent. Then you got a 3 thumbs up.
Fantastic, fantastic. So I'm an interventional cardiologist, and I don't do any cutting at all. So the things I do to valve disease is through. So I'm taking all the listeners and viewers to an even more minimally invasive zone, which is transcatheter therapy. Transcatheter therapy is a medical term for doing things to valves with devices through the blood vessels. So I get to the heart through the blood vessels. It's just to give a very brief overview of TAVI, which is a way of doing this to a very, very common valve problem called aortic stenosis. And this is a wear and tear phenomenon of the aortic valve, which is the last valve in the heart. It's the exit door to the heart. And when it wears out, it becomes calcified and thickened and hardened, narrows gradually over some years to become a very dangerous condition, which can shorten people's lives very dramatically once it starts to cause trouble and starts to impact on the way the heart functions, because the heart can't empty properly. And TAVI's been around a long time now. The first TAVI was done in 2002 by a Frenchman called Alain Cribier, and we started doing it in the UK in 2007. So it's been around quite a long time and is now very well established. It's not an experimental treatment, but it's a way of putting a new valve inside the narrowed aortic valve and either expanding it with a balloon or a frame, and has a new valve inside it, and it squidges the old valve out of the way and works very, very effectively. And it's in fact something that we can do in about half an hour, 40 minutes, with the patient awake. So we don't put our patients to sleep anymore. We seal the hole that we make in the femoral artery with a little pre-suture device, so we don't have to do any cutting and any suturing. Now, patients do have to be worked up quite carefully for this procedure. It's quite technical as to who is suitable, but most patients with aortic valve stenosis are suitable for a TAVI of TAVI, and we're lucky to work in an area where there's a lot of research. So an awful lot of research has helped us to decide who is good and who is bad and what kind of devices we need to choose. We don't just guess, we rely on a very good set of studies that have maybe 15 years. In answer to the question, who makes a good TAVI case? Well, I think everyone with aortic stenosis should at least be thought about for a TAVI, but some patients do better with surgery. We started off using TAVI only in the patients who absolutely couldn't have a surgery, where a surgical valve replacement was quite high risk, and if we could get away with the TAVI, it would be better. And we're now moving into patients who are intermediate risk. In other words, they could have a surgical operation, but they could also have a TAVI. And so quite a few patients at stenosis should be considered for a TAVI, and it should come to a well-structured MDM and an MDT, which Simon's already talked about, to look at the case in detail with surgeons and interventional cardiologists and other experts to benefit. Rather than TAVI competing with surgery, I've always felt that it complements surgery, so that actually we have another good treatment for patients, and we can really tailor the right treatment to the right patient at the right time. That's the art of intervening in valve disease. So TAVI is now really a mainstay of treatment for this aortic valve condition, which is a horrible condition and actually affects about 4% of the over 80s. So it's an extremely common condition, and we need to be doing more of it, because at the moment the UK under-provides for TAVI. In Germany, more TAVI aortic valve replacements, and that's the case in lots of countries now. And I think we've reached equipoise. So about the same number of TAVIs are done. I think it's about 7,000 a year as surgical aortic valve replacements in the UK. And I suspect that the TAVI surgical valve operation will continue to increase, because TAVI is an easy procedure, and patients are awake when they have it, and they go home usually after 2 days, and the recovery period is very, very short indeed. So my take-home message is, it's a great technique, it's very minimally invasive, it's at least as good as surgery in many, many patients, but it is complementary to surgery, and the decision about these kind of patients should always be made by a group of experts, making sure that the individual patients get the right treatment with the right expertise. But that's TAVI, Simon. I don't know whether you want me to expand on any aspect of that.
I think that's fine for the moment, Phil. I think that's very clear. But I will come back to you just to kick off the next phase of the discussion, and that is around patient choice, because this is, and then I'll perhaps get Joe to comment as well, because I think this is important, because it's clear whilst the TAVI approach and the minimally invasive approach are intrinsically quite attractive to patients, they aren't applicable to everybody. And so where does patient choice fit into this decision-making process within the MDM, MDT?
Would you like me to address
Yes,
that?
yeah,
Or?
please. If you could start that, Phil, and then maybe we'll come back to Joe. Yeah.
Well, I mean, I've always thought that the most important member of the MDT, the multidisciplinary team in general, is the patient. The patient is at the center of the MDT, and the patient should be a fundamental part of the MDT. And in fact, at King's, we often invite our patients to the MDT, and we have a meeting with them present and their relatives, and we look at their investigations together with a group of experts. And that's not a new concept. You know, patients were invited to MDTs in the 19th century in the old-fashioned days of medicine. So there's not an old concept to bring patients to these kind of meetings. And I think it's about communication, because you have to present the patient with a number of choices, and the MDT's role is to inform the patient and offer the patient choices. And the patient has to have a fundamental choice, because it's their heart. They're going to be the people that have to live by these decisions. So I think patient choice is extremely important. Communication and information. We have a duty as clinicians to let our patients know what their choices are, and also the consequences of those choices. And I think if we're honest with our patients and we have good communication, we normally come to the same decision, because we talk about the pros and the cons of each of the choices open to them. And unfortunately, when we get patients with this kind of valve disease, there isn't a no-risk option. It would be nice if there was a no-risk option where we could say, well, let's take the option where there's zero risk to you. That's not the case. We're in a situation where if we do nothing, that's usually the worst option. So we have to do something. And we can present our patients with pros and cons. And I think that nearly all the time, you're going to arrive at the same decision. But it can be difficult if the patient just says, I know you're saying that an invasive open operation is good for me. I completely understand that, but I don't want it. I want a TAVI because it's minimally invasive. That's all there is to it. And this is not new, because we've had it with stents and bypass surgery for the last 25 years. And again, that's a situation where you have to come to an agreement with that patient. You can't not treat the patient, but if that's an informed decision, then I think that needs to be taken into serious consideration.
Thanks, Phil. I mean, Joe, do you want to comment on that from the perspective of the minimally invasive approach? Because I'm sure you will have come across this this issue frequently.
Yeah, no, thanks, Simon. I think that's a very good point. I do believe that patients are at the center of the discussions, and increasingly, certainly Will and the Heart Valve Boys has made patients more aware of these options, and rightly so. I do worry about two things. One is surgeons sitting at this MDT are only seeing pictures, they're not seeing patients. And so one of the things that myself as a cardiothoracic surgeon does is I go for half the time and sit in cancer MDTs. And we always say we can tell you whether you can resect the tumor, but we cannot tell you whether we can operate on the patient until we've seen the patient. And so certainly with cardiac MDTs, it's the same thing. You can say, well, yes, we need to replace this valve, but until you see the patient, and Narain has explained the length of discussions that go on before we can make that decision. Now, the decision to replace a valve is probably much easier to do TAVI, because it doesn't matter what the patient looks like, with the size of the patient, the age of the patient. Technically, it is probably done. But we have also got to think about the long-term outlook. Now, right, like I said right at the start, patients are basically wanting to get back to work as quickly as possible. But we as surgeons have to make them aware that one of our jobs is to keep them out well in the community for as long as possible. And I'm sure Phil and you will agree that, with TAVI, as attractive as it is, we don't have the 5-year, 10-year data that kind of can give us confidence, though we certainly have the data at week 1 that they will be better than surgery. So this is one of the problems that as a group we've struggled to communicate. Now, ideally, the MDT in lung cancer works in a very different way, because there's one budget for whether the patient's going to surgery, chemotherapy, radiotherapy. But in cardiology and cardiac surgery, there are different budgets, and we know the effect of that in Germany, where you get paid more if you have a TAVI, so more patients go to TAVI. And that's something that probably will need to be addressed in the UK over time, where we share budgets and we are measured as an MDT. So we all look at 5-year survival in Manchester versus 5-year survival from King's versus 5-year survival from Papworth, and not necessarily just look at our silos, which at present we are. From a patient point of view, whether it's minimal access, whether it's TAVI, we still have to prepare them for the possibility of stenotomy, because that is our bailout and is always our bailout. And I'm sure Phil's probably come across the occasional TAVI patient who's needed a stenotomy. So I tell patients that we will do our best to avoid a stenotomy, but that has always got to be our backup plan, and that always has to be our fallback. And patients need to be prepared for that. And most patients understand that, as long as you explain the percentages involved.
No, thanks very much, Joe. So Narayan, I'll bring you back in at this point, really just to address this last issue around decisions and the explanation of those decisions to patients and family. And I think you've already touched on this very nicely in your presentation, but is there anything else you'd want to add, just in the light of what Phil and Joe have been talking about around the nuances of decision making and the need to keep patients at the centre of this and fully informed?
Thank you, Simon. It's interesting actually hearing from Joe and Phil on those things. I just reiterate the importance of understanding who the patient is in front of you and sharing that decision-making process with them. It's about us as clinicians not telling them what they should have done to them. It's about us informing them about the options, what we believe as clinicians would be beneficial to them, but allow them to make that decision. We may think that they want this valve that lasts forever, but they may not want the anticoagulation issues that come with it. They may not want the surgery that comes with it. So I think the most important thing that we as clinicians do is empower the patients to make the right decisions for them, because ultimately we will only have a shortened window on talking to them. The decisions should be made with their families, and we bring them in. COVID has brought on different challenges, but traditionally we would bring in the families when we have the discussion with the patients regarding the different treatment options. And then on top of that, because again, the clinic visit can sometimes be limited, we let them go home with information. So give them access to written information that we give them from the hospital. The consent form, as it used to be, is now a consent booklet, which has lots of information, what to expect before, during, and after the operation. There's also a lot of information available online, and the project that Will and his team have set up with the Heart Valve Voice is really powerful for patients to get a better understanding of what the different treatment options are. And then on top of that, it's important to understand patients need time to discuss these things. So a consultation with a physician or a surgeon is just start of the process of when they're making their decision. So I think, to reiterate what Joe and Phil have said, the importance of us empowering patients to make a decision, what is the best treatment for that individual patient, and we should do all that we can to help them with that.
No, thank you very much indeed, Narayan. We'll maybe come back to this theme a little bit. So we've got 10 minutes or so just to cover a few questions, and there are a couple that come up on the chat. So I think the first one I can see is relatively straightforward, and this is, can a TAVI candidate be under 80? I've been through a number of open heart surgeries, well-informed patients. At this stage, I would prefer TAVI and PPVR. Anyway, so can middle-aged patients be eligible for TAVI? And I'll direct this to you, Phil, but I will preface this by saying middle age is a moving feast, depending on how old you are yourself. And so I'm not going to ask you to perjure yourself, Phil, but just comment on the age issue.
So I don't like age cutoffs, and you know, absolutely TAVI is available to under 80s. It's available, should be available to anyone of any age if the profile fits and if the heart team feels that TAVI is the best option. And certainly we at King's deal with very complex patients who've had multiple cardiac operations. They've had 3, maybe 4 previous cardiac operations, and the prospect of doing a further major heart operation is overwhelming, not only for the patient but for the surgeon. The risks increase with every operation. So each patient should be considered on their own merits and their own risk profile, and that's exactly the the purpose of the heart team to examine the details of that patient, to look at the tests, and to say, well, you know what, I think the best way to do this and the lowest risk to treat this is the following. And that could often be a TAVI if that individual patient was suitable for a TAVI and if everyone in the heart team agreed. So absolutely. I don't think we should have absolute age cutoffs. I know Simon and I have had some discussions about MDTs yesterday, but age cutoffs are arbitrary. And we've all seen, you know, I've got TAVI patients that first presented with shortness of breath whilst skiing on a glacier, aged 92. One of my 92-year-old patients did aerobatics in a tiger moth to celebrate his 92nd birthday. So age cutoffs are arbitrary. Each patient needs to be considered on their own merits.
Yeah, I mean, I think that's a very good answer, and I would absolutely concur with that. It's around fitting the available techniques to the characteristics of the patient rather than coming up with any sort of arbitrary cutoff. I mean, you can have broad guidelines around when certain techniques may be more applicable to the majority of individuals of a particular age group, but of course that doesn't allow for individual variation. So I think you're spot on there, Phil. There was another question which reads TACO for mitral, but I'm assuming that I will translate that as any percutaneous options for mitral valve disease. Will's nodding. So again, you're monopolising the discussion here a little bit, Phil. But do you want to just summarise briefly what the percutaneous options are now for mitral valve disease, accepting that they are nowhere near as mature as the TAVI technique for aortic stenosis?
Yeah, there's two broad categories very quickly. One is if someone already has a surgical mitral valve, so an artificial mitral valve. When that starts to wear out, we can put a TAVI valve inside that surgical valve. We've been doing that for 12 or 14 years. That's not new. The larger group of patients are patients who have a problem with their own mitral valve that they were born with, and we're doing things to mitral valves at an increasing pace. And the one that people may have heard of is called the MitraClip. That's where we clip the two leaflets together, and that's been shown in recent trials to be a successful thing which decreases mortality and decreases patients coming into hospital. So MitraClip therapy, where the edges of the mitral valve are clipped together, is becoming a mainstream treatment. There's a whole load of other things that are under investigation at the moment, and it's a very growing area. But the last thing I'll say is the mitral valve is a lot more complex than the aortic valve, and it depends on the whole heart and the way the whole heart functions, and particularly the pumping chamber. So assessment of these patients is really, really tricky, and we really need our colleagues who are experts in echo and other imaging techniques.
Simon, yeah. I've got a couple of questions that have come in through Facebook and Twitter, if I can just ask those. One is, during COVID, we've obviously seen more telemed, and the fact that perhaps MDTs and NDMs are taking place online, whether GPs get involved in that, as well as family members. We've had one question that I think it's a bit more of a flippant one, but what's the most common question patients ask just before a treatment to their clinician or that surgeon? And what's the most bizarre you've ever heard as a treating clinician?
Right. So I will. The third one, I'll leave the rest of the panel to think about. Well, I'll have a stab at answering the first two. So, in terms of the MDT and GP involvement, traditionally that's not been the case. But we are, as Phil indicated there, we're in the process of rewriting guidance for MDTs, partly because the time is right to be re-looking at it, but partly also because of the circumstances that have been enforced on us by the pandemic and the switch to virtual MDTs. And it's a very well-timed question, because of course the virtual environment does allow, at least in principle, the presence of a lot more people in the room than the old physical MDT did. And I think there are considerable advantages, not necessarily in every case, but certainly in some instances, for GPs to be involved in the same way that Phil has indicated, for patients and their families to be involved. So I think in particular instances, absolutely, that is something that should be possible where it is considered to be relevant. The second thing is what's the most the commonest question prior to an intervention. I mean, I can't speak for surgery, but from the point of view of the cardiologist, it's usually, when can I get back to normal activity? And that's the thing which I'm certainly asked most often. And I think that is one of the things, not the only thing, which is move towards increased TAVI and to some extent towards minimal invasive surgery, because of the perception from patients that they will be getting back to normal activities more quickly, which, you know, if you're employed or you're a carer for children or elderly relatives is particularly important. So I'm conscious we're almost up to time, so my co-panelists will have had time to think about the most bizarre question. So I'm not going to direct that to anybody. I'm asking for volunteers, Joe or Phil and Lorraine. Anybody wants to answer that one? Joe, you're off mute, so you go ahead.
I think I was just trying to think of something that's not too shocking, but I think one of the things that I'm sure Phil's probably come across as well when you do minimal access is patients coming and saying, I do not want a conversion to stenotomy. And I had a patient who was insistent that I'll have the operation keyhole, but if you have to convert me, wake me up and send me home. And that sort of discussion is just very difficult, because you have to say this is part and parcel. We're going to give you a holistic approach. 97, 98 or 100 times we'll do it keyhole, but we have to have another option available. And so, yeah, sometimes you do get great expectations, which you have to manage.
But could I just add that patients shouldn't be afraid to ask any question, no matter how bizarre they think it is. So I would wish to just strongly say, if you've got a question, if you think it's weird or bizarre, or don't be afraid to ask us. The chances are we've heard it before, and it might be important to you. So the message, I think, from you, even if you think it's really odd or no one ever asks it, just ask the question.
Yeah, I would agree with that, Phil. I think that's really important. Lorraine, any final comments from you?
No, just for patients to understand that we want to do what is best to support them in the decision-making process. My bizarre random things are mainly related to the patients expecting if I fix their valve, I'll fix every other part of their body. And alas, surgery is great, but isn't that great. So yeah, we welcome them to engage and ask any questions they want.
So I think that's a really good parting note, actually, and I would echo that very sincerely, that if you have any lingering doubts, it's much better to ask, because any sensible cardiologist or cardiac surgeon will go out of their way to respond to any queries like that, because uncertainty is a really difficult thing to cope with, as we heard a little bit earlier on. So thanks very much, everybody, and back over to you, Will.
Yeah, thank you very much, everyone there. I know we had some other questions that from Sue. We had questions about the Ross procedure and various other things. We'll capture all of that, and it will be in our Q&A document. But thank you very much to the panel. I really appreciate it. You're all very busy, and it's wonderful that you've found some time to talk to the Heart Valve Voice community. Thank you.